So welcome everybody to what's now the 14th COVID Summer School Series that UCD, myself, Fiona McNicholas, my colleague Blona Gavin, Paul Harkin, who's assisting us throughout, and we're co-hosting this with the College of Psychiatry in Ireland. So we're delighted to welcome you all again back to the Friday lunchtime show. Believe it or not, it's coming up to the end of August, and school has started for some people and is about to start for more people next week. And it's probably going to mark a new era for us all during this period of COVID. You're familiar with the chat facility, and we'll have a 45-minute presentation by our guest speaker, followed by questions and answers at the end. If any of you would like to put them to me in writing during the talk or at the end, or indeed if you wish to raise a question yourself, alert me to that and I will give you time to speak. So we're very, very excited with our guest speaker today, who's presenting to us from Canada, so apologies, it's before his breakfast time, but particularly on account of the topic of his both research and clinical experience. Professor Prof Maunder, known as Bob, is Professor in Psychiatry in the University of Toronto. He's also head of the research unit in Mount Sinai and has recently been awarded a grant to study some of the harmful effects of COVID on healthcare workers. Bob, I read a little bit about your biography, your research prior to this presentation. And I guess what's really, really interesting for myself as a liaison psychiatrist is that key role you seem to play between the patient and the clinician, but also understanding the psychosocial adversities and indeed the history of trauma and attachment in terms of, I suppose, resilience and ultimate health during adult periods. And much of your clinical and research work is in this area. So the topic of Bob's talk today is reducing the harmful impact of COVID-19 on healthcare professionals. And we'll be very interested to learn about the specific focus and opportunity, I suppose, within the resilience coaches to do that. So Bob, over to you, and thank you.
Okay. Well, thank you very much for that introduction. Thank you very much for having me. I'm delighted to be able to be part of your lunchtime COVID seminar series. So I'm talking today about the impact of COVID on healthcare staff, particularly in hospitals, because that's what I'm most familiar with. And I'll talk a little bit about what we learned, because our hospital was one of the hospitals in Toronto that was affected early on in the SARS outbreak in 2003. What we learned from that, about its impact and about how to build resilience and protect our staff, and how we're trying to apply that currently. So as Fiona mentioned, I'm going to talk about coaching, which is the way that we're trying to support our staff at our own hospital currently. So we'll get to talking about what exactly that means. What is a coach, and what is it that we're trying to do, and our efforts to demonstrate that we're having some impact. So as Fiona mentioned, my research is in attachment and childhood adversity. I'm a consultation liaison psychiatrist, but I'm primarily academically interested in how relationships affect health. And that's the kind of work that I was doing with my colleague and collaborator, Jon Hunter, in 2003 when SARS broke out, and Toronto was one of the affected cities. So it was never my intention to be studying the impact of infectious diseases on hospital workers or healthcare workers. It just we were forced into it by circumstance. So I'm going to just talk very briefly about the impact of SARS, and then a little bit on how that's different from COVID, because it gives us some information about what we could expect this time around, but it's also, we need to put it in context because COVID and SARS are pretty different. The place to start with is to recognize that healthcare work in general has high occupational stress. So this is it's a difficult occupation, and there are consequences of chronic stress when healthcare is working as usual. So healthcare professions are associated with high rates of burnout, rates that vary quite a bit actually from one study to the next and one context to the next, but typically somewhere in the range of 1 in 3, 1 in 4 healthcare workers meeting criteria for burnout variously defined. We work, especially in hospitals, especially for nurses, in a context where there's a startlingly high level of physical abuse and verbal abuse that healthcare staff experience. And there are many signs of chronic stress, including higher rates of suicide, particularly in some professions, and recent evidence suggests particularly for women in healthcare. So that's the background upon which any new extraordinary stress occurs. So when SARS came in 2003, of course, nobody knew what it was. The pathogen was identified fairly late in the outbreak. What was known was that there was some new infectious disease that was seemed to have high infectivity at the beginning, higher than actually turned out to be the case, and seemed to have high mortality at the beginning, much higher than turned out to be the case. And so it was a frightening experience as that emerged. In Toronto, Mount Sinai Hospital, where I work, was I think the second hospital to have SARS cases, and so we found ourselves being a SARS hospital. One of the characteristics of SARS that was particularly difficult for our colleagues were that many of those infected were in fact healthcare workers. So we had SARS units on the hospital that were kind of jerry-rigged negative pressure units because we didn't have enough negative pressure units at that point. So we had like plastic sheeting and whatnot covering over these wards, so it looked like a MASH unit from the army or something. And inside the SARS units were the SARS patients, all with their doors closed, all in individual rooms, and at least half of them were our colleagues. And so we, as CL psychiatrists and social workers and chaplaincy, the disciplines that we were working with, set about kind of proactively trying to support our colleagues who were affected with SARS, without waiting for a request for a consultation, which was outside of our usual routine at that point. And there wasn't anything else to do except for care for SARS patients because everything else in healthcare essentially got shut down. So we had these kind of extraordinary days where our mornings were stressful, weird days where we would make rounds on the SARS wards with all of our PPE and being unrecognizable to one another. And then in the afternoon, we would go back to our offices and have nothing at all to do. And so we spent those afternoons trying to figure out what the heck was going on, what we were observing, and what we could do about it. And that was kind of the beginning of this enterprise of trying to understand the impact of extraordinary infectious outbreaks and what to do about it. So we, as many others did, studied the acute impact of SARS, which in retrospect is not a very valuable enterprise. There were dozens and dozens of papers showing that the acute period was quite stressful for people, which you could have known without data. And the same thing is happening with COVID. There are dozens and dozens of papers showing that the acute period of the onset of the illness is quite stressful in healthcare situations, which again is not surprising and doesn't add too much to our understanding. And then we set about trying to do some more systematic research to try and understand what the chronic impact is going to be. and studied, because SARS was a relatively circumscribed outbreak, so there were places that were affected by it and places that weren't. We were able to compare SARS hospitals to non-SARS hospitals to get a sense of what the long-term impact was. And what we found was that the long-term impact of SARS on people who were working in hospitals at the time was not exactly what we expected. It didn't actually generate a lot of new mental health diagnoses. There was very little new onset of depression or anxiety disorders, or virtually no new onset PTSD. There were a lot of signs of kind of the behavioral risk factors, behavioral risk indicators of chronic stress. So high rates of burnout, psychological distress, more sick days, people reporting interpersonal problems, more substance abuse. And we found that for as long as we looked for it, which was 18 months to 2 years after the outbreak. So going into COVID and approaching the H1N1 pandemic, which was the last thing that we tried to prepare for with resilience, that's what we were aiming for, to see what we could introduce that would decrease those kind of chronic stress effects as opposed to trying to mitigate mental illness. So I said it's worth emphasizing that we're always working with the information we have from previous events, but generals are always preparing for the previous war. And so what we learned from SARS is in some cases applicable and in some ways not applicable to what we're experiencing with COVID. There are a couple of things about COVID that are better for healthcare workers than SARS was. We knew what the pathogen was from very early on. It was quite extraordinary how quickly things were identified. And for the most part, this is not a hospital-based illness, and so there's less stigma, and there's a lot of anticipation of risk, but there's less risk that's associated with working in a hospital than there is for infection. And less stigma. So so those things are different, and those differences are a little bit better. Almost everything about COVID though is worse, and you don't need me to tell you about this because everybody's experiencing it. That's one of the characteristics of this pandemic, is that it's universal. This is much more infectious, more lethal. It's lasting a long time. SARS had a beginning and an end. So we could talk about during and after SARS, and so far we don't have the ability to talk about after COVID. And it's accompanied by this huge social and economic impact, which has a tremendous effect on the sorts of things that we're trying to help each other with when we're dealing with resilience and psychological distress. It's the economic impact, the shutdown of schools. Fiona said you're about to return to school. We're about to return to school too, but none of us really know what that means. It's not a well-organized or orchestrated return to school process, at least for us. So I think there's a lot of parents just waiting and wondering exactly what's going to happen in the next couple of weeks. Okay, so on to talk about what we've learned about how to prevent and mitigate those harms. And the principle that I'd like to emphasize is that we can talk about individual resilience, and we can talk about the resilience of organizations. And they're each worthy targets of trying to build resilience. But I want to emphasize that I think it's important to put organizational resilience first. So we want to focus first on the system and second on the individual. And the reason for that is one of principle, almost of ethics, as much as based on what works best. Because I think it's typical for everybody's reflex to be to focus on individual resilience. So if you look at the literature, there's a lot of resilience work that's focused on kind of CBT-based or stress relaxation-based interventions for individual healthcare workers that are intended to help them maintain resilience. And there's some evidence that those work. I would say on the whole, the evidence of any resilience efforts being terribly effective is weak at this point. But there's some evidence that those individual resilience efforts work, and they're definitely valuable. But there's also an unintended downside to focusing exclusively or primarily on individual resilience, and that's that it tends to put the onus or responsibility for being resilient on the individual. And so there's some pushback against that it's kind of victim blaming, that particularly when you think about the kind of routine, normal occupational stresses of healthcare work, a lot of them are related to the system working in a way which is harmful for or fails to be protective for individual healthcare workers. And so if you start from that premise and then put the emphasis on the individuals for maintaining resilience in spite of a stressful and harmful system, then you can understand, I think, why that would be not always experienced with great welcome by all healthcare workers. So I think it's really important, certainly in the messaging and also in the application, to focus on what we can do to make our organizations as healthy and resilient as possible, and then include with that what we can do to bolster the resilience of individual healthcare workers. So we took a look, this is coming up to the expected flu pandemic in 2009, if I remember right. We took a look at the literature to see what we could learn about building resilience in advance of an event. We had to look broadly because the medical literature was kind of weak to moderate on individual resilience and pretty weak on organizational resilience. I mean, so we looked a little bit more broadly, and including at literature from businesses, and especially those who had been through 9/11 in New York, and which ones have emerged from that stronger, and which ones have gone under, and what the kind of different characteristics of those organizations were. And so we kind of talk about prior to an event, the preparation phase, and then what to do during an event, the execution phase. And so there's a lot of emphasis on building reserves as part of preparation. Building reserves in the business world mostly means money and stuff, and mostly means money. So that's important for organizations. It's way beyond my pay grade, so I don't pay as much attention to that. Also building reserves in terms of organizational processes, so succession planning, skills building, training, so that people feel like they can be nimble and move into different roles because they're familiar with them, and that builds reserves that are useful when an event comes. And what we've added to that based on our SARS experience is that it also helps to build relational reserves. An organization works better if people know each other. And as health psychiatrists, we're familiar with the advantages that come from having working relationships with surgeons and internists, nurses, and the people in the hospital of various disciplines, that when we have those pre-existing relationships, we can use those relationships to provide support and be more responsive and be more useful in an extraordinarily stressful event. And so the idea of kind of building relationships prior to any kind of extraordinary event, I think, is an important one. And focus on the importance of planning. And I won't talk about it in any kind of depth for lack of time, but there's also kind of organizational structures that are more likely to lead to healthy staff, and in fact lead to better clinical outcomes for patients as well. And some of those have been described in the nursing literature related to what are called magnet hospitals, and also some principles of just processes, transparent and clear and fair processes within hospitals that lead to better outcomes. at when we're actually in the midst of an event, as we are now, and trying to execute a good response to it, I've highlighted the British Psychological Society guidelines to responding to psychological needs of healthcare staff, because they're quite a good practical list of things that can be done at the level of kind of middle management up to higher leadership within healthcare organizations, where we talk about the importance of visible leadership. It's really beneficial for people to know that the executive, whoever are kind of considered the leaders within the organization, are actually present, which just means physically present, like that they show up, that they ask questions, that they're interested. Communication is so important, and inevitably goes wrong in a circumstance where the information that needs to be communicated keeps changing, right? And so there's inconsistency, there's a lack of clarity, things happen in different ways within different hospitals, within different organizations, within different departments, and that tends to foster mistrust and anxiety. And those in charge of communication, in my experience, will almost always try and spin communication so that it sounds most positive. And communication that feels spun tends to be less trusted. And so there's a lot of effort into being really clear, really honest, timely, transparent, including saying what we're telling you now may well change because we're about to get new information and we don't know what that is yet. So we're going to kind of anticipate that things are going to be inconsistent and change over time. Okay, so then at the individual level, we have focused on a couple of principles and we've used these in the coaching work that we're doing and other work. One of them is the principles of psychological first aid. We don't do psychological first aid. That's really focused on kind of post-disaster interventions. But we steal the principles, which especially that we interpret people's distress as ordinary, normal, expected distress in an extraordinary circumstance. We assume that people are psychologically healthy. We assume that our job is to help them return to a normal level of coping, that we're dealing with good copers who are temporarily overwhelmed if they're overwhelmed. So the principle is not to pathologize. And that informs efforts to kind of normalize the stress response and help people understand themselves that this thing that feels potentially pathological and extraordinary is an expected response to what they're going through. We have adapted an approach to coping from Folkman and Greer that was developed for coping with cancer 20 years ago now, I think. And we've adapted it to make it more stepped and staged than in its original description, to say there are 3 steps to coping. And we use this because it's simple and easy to remember. I highlighted a YouTube video that Jon Hunter and I did for our colleagues. Step 1 is problem solving. So do what you can to fix the problems that can be fixed. Step 2 is emotion-focused coping. Do what you can to feel better in spite of things that you can't fix. And step 3 that we get to least often is meaning-based coping. So for things that involve enduring suffering, where we can't feel better, focus on meaning, values, and purpose, why we're doing what we're doing. And then the last principle is from Paul Slovic's classic work on perception of risk, that human beings are terrible estimators of the degree of risk that they're facing. And so we overestimate and underestimate risks all the time. And that the 2 dimensions that determine that often are familiarity and degree of personal control. And so if we take things that are very familiar and involve a high degree of personal control, like driving a car, we tend to vastly underestimate the risk that's involved in doing that. And if we're in a circumstance that's unfamiliar and there's very little personal control, like a global pandemic, then we tend to overestimate the risks that we're facing. And so that helps us to kind of focus on what we can do to increase personal control over proximal processes and increase familiarity with what's going on as a way to allow people to assess the risks that they're involved with as accurately as they can, which helps to manage anxiety. Okay. I don't need to say anything about those things. So the coaching initiative takes this background, so experiential background, because some of our coaches have kind of been through this whole history of SARS and the H1N1, which turned out to be not a very severe event, through to COVID, plus the kind of evidence that's built as a result of that, and to try and apply it in a practical way for our peers. This emerged in March, I guess. So we I was trying to remember when the NBA called off their season because of a player becoming infected, and I didn't look it up, but that was, at least in North America, that was kind of the signal post of like pre-post, COVID is a real thing now, with everything getting shut down. I think that was in March. And so as hospital processes changed, we started having screeners at the door, and people were discouraged from coming to work, and patients were discouraged from coming to the hospital. And we were anticipating the onslaught of new cases and whether our ICU would be overwhelmed. We were very much in that kind of anticipatory phase. We, as a department of psychiatry, were trying to figure out what we should do. And so we started offering support to the various parts of the hospital that were looking for it. And as we offered, more parts of the hospital were asking than we had the capacity to deal with. And so we started building up like an actual process rather than just kind of ad hoc responding. And what that resulted in was a group of about a dozen psychiatrists, all of our CL psychiatrists, some of our ambulatory psychiatrists, some of the residents who were working with them, a advanced practice nurse, a social worker, and a bioethicist at the hospital, banding together to form a group that would provide support to the units that were looking for support. And we decided to call ourselves coaches. And the requests came from all over, so medical, surgical units, from the executive administration, the nursing unit administrators, the screeners, some of the long-term care homes that we're affiliated with, the requests for support. Once it was word got out that it was available, it was kind of widely sought after. And we decided to call ourselves coaches, and we actually spent a little while trying to figure out what the heck to call ourselves, because it's an invented role. There's no name for what we're doing that I'm aware of. It seemed important to name it something, just for ease of suggesting to others that we had something to provide, but also to name it something that would distinguish it from relationships that would be that could be problematic because they're not quite what we're trying to do. So we wanted to make sure that we were not seen as psychiatrists for patients or as healthcare providers for patients, where the colleague is the patient, because that's not the relationship that we have, and we're not buddies. And although people sometimes expect us to teach, we mostly don't teach. So it wasn't clear exactly what we should call ourselves. But we settled on coaches as a word that could try and reflect that we are peers with some expertise who are involved in the same struggle, but offering some guidance. And the coaching seemed like a relationship that was explanatory and familiar enough and kind of calming, right? So the people like the idea of having a coach. So what do we do? Well, it depends very much on who we're talking to. So what we do primarily is we kind of embed ourselves in a service. So there's no kind of rotation format. Bob is connected to 14 South, right? And Ben is connected to the emergency department, and we try and maintain those kind of continuous relationships, which is, I think, is really helpful. And that's part of that idea of relational reserves, that support works better from familiar, reliable relationships. And then what we do with those groups depends very much on what they do and what's useful. So we attend huddles. In the ICU, they have an early morning huddle every day, and so the psychiatrists that are supporting them show up for these huddles and are so those are in person. The ICU is a pretty small, high contact area and remains so through COVID, and so we participate in that. Whereas other areas like the family practice unit is doing virtually everything virtually, and so we join them through Zoom meetings. I tend to sign over rounds, sometimes go to ad hoc sessions if there's some kind of extraordinary bad event and people want to have a meeting about it, then we'll do that. So that the structure is quite variable and flexible. We listen more than we talk. We facilitate discussion more than we teach. We try and help people surface feelings and surface issues. We work in a profession that is very problem-solving focused, very much more reactive than reflective, and we try and give people a little bit of space to do the opposite of that, right? To be a little bit more reflective, to talk a little bit more about the impact that their work is having, as opposed to just how to fix everything. Sometimes we will try and facilitate some advocacy. So some of the things that arise are issues that seem like they could use some advocacy, often to the senior management in the hospital, and so we will try and facilitate that. We try not to take that over, but to kind of provide a voice or conduit for those kinds of concerns to get to the executive. When we do anything that is teachy, it's very often normalizing, validating, normal stress response, the kind of 3-stage coping, sometimes a little bit of relaxation or breathing exercises, those sorts of things. And because of that contact, we're often the ones that help facilitate some individual support for somebody who is particularly in need of that when we get it. But we see that as a kind of add-on to coaching. It's not the intent of coaching, but we'll try and hook somebody up with individual therapy or support or whatever they need when they're looking for it. And then we meet with each other once a week for peer supervision. In Canada, we have Hockey Night in Canada, which is the featured hockey game of the week each week. And between periods, there is something called Coach's Corner, where experienced coaches give the play-by-play and commentary on what's happening in the game. And so we call our weekly meeting Coach's Corner, which will mean very little to people from outside of Canada, but makes us happy. And the, just to say, we feel like we kind of invented this for our hospital, but we're not the only game in town. There's lots of other places that are doing similar sorts of things. There's a good document out of Rush University describing what they call a toolkit for responding to COVID-19, which describes something that's actually very similar. And I'm sure there's other examples. So what do we find? Well, over time, our experience, which I'm sure is will be similar to yours in many ways, is that the kind of themes that have emerged have changed over time. It have been very much on the kind of phase of the pandemic and what we're in at the moment and kind of what we're anticipating coming up next. The distinction between anticipation and an acute event is an important one. The anticipatory phase is almost always more anxiety provoking than the actual doing. There will be exceptions to that for sure, but the exceptions are exceptional. So places that are in fact overwhelmed by the number of cases and the intensity of infection will find the acute event to be worse than the anticipation. But for most places, the anticipation is the worst case scenarios that are more bad than what actually happens. So we had a lot of work to do in, I'm losing track of time now, but March, April maybe, in anticipation of the kind of early peak. And then the work of supporting people through the actual peak was a different sort of work. And then things have kind of quietened down over the summer for us locally. So then there's issues of those who are working inside the hospital versus those who are working outside the hospital, because everybody who could work from home was encouraged to work from home. And like many things in this pandemic, it's easier to shut things down than it is to turn them back on. And so initially there was a different feeling for those working at home than those working in the hospital. But that different feeling would vary from a person to another. Some people were quite frustrated by being at home. Some people were quite relieved by being at home. Some people felt guilty. I mean, there's lots of ways to react to that, but it was quite different than being inside the hospital. And the sense that we were kind of divided, it tends to be a little bit subterranean. I mean, we haven't had a lot of conversation about that, but it's a real thing, and people will speak to it. And one colleague identified this as the frontliners versus the sideliners, and you can imagine how that split feels on either side of it. And now this is coming more to the surface because people who have mostly been working from home or entirely been working from home have to figure out how to come back to the hospital and when. And there's no clear direction about that. It's not like anybody's saying, you know, on September the 3rd, you need to start working from the hospital again. But at some point, there's kind of a gradual creep back into the hospital. For some people, like in psychiatry, and I think it would be the same in family medicine and some other specialties, it would be coming back into the hospital to do virtual care from the hospital as opposed to doing virtual care from home. But even so, that's a difficult transition for people to make that have been away for many months. Early on, there was quite a lot of anger, less so during this kind of quieter phase, but anger about being put in harm's way, about, especially early on, about whether the PPE was going to be adequate or inadequate. Conflicting advice that the nurses in our area the hospital recommendation was to be wearing procedural masks, for example, whereas the nurses union was telling them that nothing would keep them safe but an N95. So they were in the position of not knowing who to trust and not knowing whether to trust the equipment that was actually supplied to them because their union was telling them that it was not adequate. So those kinds of conflicting messages were generating a lot of stress. I found moral distress to be a really useful concept, and this I've learned from our bioethicist, the idea that being in a circumstance that prevents you from providing the level of care that you're used to providing and that would be optimal, so that you're actually doing a less good job, but you're forced to do a less good job because of your circumstances, that causes distress, and that's moral distress. And it's a helpful concept because without that concept, we tend to just call that guilt. But the idea of guilt is a little bit misapplied there, where you're not actually doing anything wrong. It's the circumstance that's forcing you into this kind of ethical dilemma of doing your best, which is less good than what you would usually do and what you intend. So that's been a helpful concept. And widely applicable, because all the people who are working in hospitals are also parents and children of elders and partners, and kind of faced with these dilemmas of how to balance these roles in a way that feels compromised often. We're very much into the marathon rather than the sprint now, and so we've had a lot of episodes on self-care and feelings of burnout. Issues of wanting some recognition, wanting validation, acknowledgement for doing the work that we're doing, but some ambivalence about how that's received. I don't know if the hero narrative has been strong in Ireland. It was certainly strong here, not so much recently, but in the spring it was. So the idea that healthcare workers are heroes, nurses especially are heroes. And some people like that and find that validating and appreciate the recognition, and some people find that quite uncomfortable because it doesn't actually feel like it fits, because they're doing work that doesn't feel heroic, or perhaps they're not right at the front line. They're in some role that's a little bit further back. So the sense that maybe somebody else is a hero but I'm not. So there's ambivalence about that was an issue early on. And then a different kind of reaction to that as that narrative kind of faded, and like people in the ICU saying, well, I'm still doing the same work I was doing 3 months ago, but now I don't get to wear a cape anymore, because nobody thinks that it's heroic. It's become familiar. And all of the issues of disconnection from family, and a lot of uncertainty about what that means without clear guidelines about, if I'm working in the emergency department, what does that mean about when I go home? Like, do I get to just treat it as normal when I go home, or should I be separating from my family, especially young ones or older ones? And people kind of making up their own rules, really, about what is a satisfactory level of safety for themselves and their families, and having to kind of manage whether those are the appropriate rules or not. And I'm just finishing up. We've had challenges as coaches. One of the challenges is role conflict, which comes up in consistently on Coach's Corner every Friday. We're often talking about how to manage potential conflicts in our roles. So being kind of peer coaches, supporters versus psychiatrists, mental health experts. When is somebody a patient and when are they not a patient, right? And we try and make a really clear division. If somebody becomes a patient, that's very much divided from the coaching role. But the clear division is a solution to the actual experience not feeling so discontinuous as that, right? And so that's one stress that we try and manage. The idea that we are trying to support people through a difficult circumstance, and yet at the same time we're experiencing it, and which is usually not part of the conversation if we're out in our coaching role. So that's a little bit of a tension. The idea that we are an advocate for our colleagues, which is, I think, our preferred role, versus being understood to be an agent of the hospital, which in some senses we are too. So that's like an actual conflict that's important to surface and be as transparent about as possible, so that it's so that we're not like secretly being an agent of the hospital. and I've spoken to the need to figure out how our role shifts as the pandemic shifts. And the question that was raised when I spoke about this in another setting, the first question was, how do you pay for it? Which just we went to do this without a plan for how any of this was going to be paid for, how much time was going to be paid for. We kind of cobbled it together as we go. But if we're going to be evangelists for this being a model that is useful to apply in other places, then there needs to be a conversation about how it can be sustainable. So the impact, the evaluation so far is informal. We're the more requests we get for coaching, the better we feel about how it's at least perceived to be useful. We get senior management asking for our guidance on communications and what the impact of various decisions they might need to make. That gives us a sense that maybe we're doing something useful. We had the hospital for a period of time decided to provide free coffee and tea for staff and to subsidize parking, because everybody switched from most people who were working at the hospital switched from riding public transit to driving a car if they could, in order to reduce contact and reduce risk. And that was actually something that was encouraged. And then they get downtown, and parking is tremendously expensive in downtown Toronto. And so they were effectively penalized for bringing their car to work as they were instructed to. And so the hospital started subsidizing parking. And those, we think, were a response to advocacy concerns that we were bringing forward from our colleagues to the executive. So that felt like a win. And quite a few units have asked us to keep showing up and keep doing this, even though there's a lot of acute COVID activity at the moment. So it seems like there's a kind of perception that this is useful. And the last thing I'll say is about the research study that, so this is one of the ads that we're using in the hospital to get people to sign up for a series of surveys that are surveying distress and burnout and the other sorts of things that you would like to measure to see how well people are doing through the pandemic. And we're right in the process now of hiring a couple of peer resilience champions who will likely be nurses or social workers who are going to do this kind of work on a paid basis and as over the next 18 months. And this graphic is just to telegraph that we're going to be doing these surveys repeatedly at 3 months intervals over the next year and a half or so. And with a step wedge design, we're going to introduce these peer resilience champions area by area through the hospital until the whole hospital is getting that intervention, to see if we can get a quantitative indicator of whether this kind of intervention makes any difference or not. And at the same time, we'll be doing qualitative interviews and analyzing the themes that emerge from the coaches and those who are being coached. And I think I kept to my time commitment and didn't have to be pulled off with a hook at 50 minutes. And now we have a little bit of time for questions and answers. I cannot hear you speaking, Fiona.
All right, I'm using a work computer that doesn't like putting anything into it that doesn't belong to my organization. So that goes for the headsets as well. I was just thanking you, Bob, and I was inviting our participants to feel free to show their faces if they would like, so that we can see the names, the faces behind the names. Bob, what struck me as you were talking is, this idea of the marathon and the fact that actually it is going to extend not only months but years into the future, and how we prepare ourselves for that. And I'm very mindful of research that we've already conducted in Ireland amongst our own child psychiatry consultant group, where really pre-COVID, there was already very high stress levels. And this was very much linked to, chronic neglect and underfunding and increased demand. And interestingly, a perception of lack of government and organizational managerial support for the role we do. And I guess one of the things you're talking about is our ability to continue to be resilient is so dependent on the organizational structures that will support us. So we're already within the child psychiatry group, and I know we're also doing research in this area in adult psychiatry as well. Will be interesting to look at, and indeed I'm sure there are many others doing similar research. But as we're kind of trying to look at our own resilience as we go forward, the issue of the organizational need to support us is something that is going to be of great concern to us. How do you think, you have suggested one method, which is the coaches, the resilience coaches, or the peer support. I work in a number of different facilities, and there's different approaches, regular letters, a little bit like the hero clapping. You kind of feel you stop reading letters because they're very irrelevant, and it's kind of all clap on the back. But actually, I'm not aware, and maybe in some organizations and participants might respond to this, of whether managers are actually coming down and asking workers, healthcare professionals, what they actually need to try and optimize their working conditions. And is there a process for that in Mount Sinai? And is that part of what you do as a standard within your program?
Well, that's one of those gigantic questions that's hard to structure an answer to. It's the right question. Because I completely agree that we need an organizational response first, and organizational process is a system that not only claims to want to support its staff, but in fact does, right? Because those are intentions that are in the value statements of most organizations, but it's kind of like what is actually done that makes the big difference for whether people feel supported and work in a place that allows them to be resilient or not. So I don't think there's a simple answer to that. I certainly don't have one, but it's also hard for us because if I can assume that we are similar in what we do, other than the fact that I'm an adult psychiatrist and don't know the first about kids, we're good at dealing with individuals, and we're good at dealing with small groups of individuals, up to the size of a family or like a therapy group. But we're not, by and large, experts in organizational processes or organizational structure and how to change organizational structure, right? So we can recognize the need for advocacy, but we're not necessarily experts in that advocacy. Right? And that's certainly the position that I'm in, right? So I try and speak to this whenever I can, right? And we certainly try and work like locally within our own organization, within our own hospital, to kind of build up our standing in psychiatry, build up our standing with the executive and with the organization, so that we're kind of part of the conversation. And I think that that's worked out. I think they're receptive and are trying to work with us to understand what we think would be most effective for the organization and trying to implement that. But we have different agendas, and we're not the experts in that, right? So it's a difficult struggle. Like everybody recognizes, I think, that healthcare work is high stress, high burnout kind of work, and that there are a lot of contributors to that, and you've listed some. But when it comes time to do something about that in a hospital, most people's first idea is, let's have yoga, right? It's like, so it's the reflex is always to focus on the local, the small, the individual, rather than on the forces that are causing that burnout. And some of it goes like much more broadly. Like I don't know how, I don't actually know the health economics of funding healthcare in Ireland. I know how it works locally in Ontario, but like who's getting paid and whether they're getting paid and how much access there is and which patients are getting care and which patients are being left out, like all of those are like determinants of the healthcare workers. They go like well beyond the local organizations that we work in.
Well, I guess just to answer the pay, suffices to say that the services are underfunded for sure. Mental health gets a tiny proportion, but also you're not funded based on your volume of work. So the more you see, there's no incentive, financial incentive. And so that's also a difficulty in that sometimes the tensions exist between services by way of trying to cope themselves, closing down, and patients then become kind of kicked from pillar to post. But just in reading some of your own clinical work and thinking about how different people respond differently to stressors, how do you line organizational responses to a broad group of people? Some people who prefer, to defend and kind of withdraw themselves as a way of, as a healthy way of coping, and other people who need that outreach and need somebody to reach into them. So within your own service, in terms of the pragmatics of these coaches, how are the teams or the groups that ask for them, how are they formed? And does the person self-select to attend, or is it the leader of the team decides, well, we're having one of these coaches and everybody who's at the huddle is exposed to the coach, whether they like that or not?
Well, yeah. So, I mean, in principle, we start from things being voluntary. Like, so we're not showing up except when we're invited. From our point of view, people are free to attend or not, although it's actually the local culture that's determining that to some extent, right? So the nursing unit administrator, I don't know what you call them. They used to be head nurses here. Anyway, the person who's in charge of the nursing unit may well have the kind of relationship with the group that makes attendance feel more compulsory in some places and less in others. I know in the ICU, when they go up for a huddle there, one of the things we've talked about at the coaching meeting is the psychiatrist who's doing the huddle is kind of watching who's participating, because there's a big group of people that kind of form like an actual huddle. And then there's some that don't, right? They kind of keep doing rounds around the outside, who are actually typically the physicians. They're just as invited, but not participating. You can kind of observe the dynamic, and sometimes the huddle is bigger and closer, and sometimes it's more distributed and less people are involved, and it's kind of a marker of how people are feeling about the coaching perhaps, but often just about kind of local stresses and local dynamics. And so it's like one of the things we observe, but we don't manage, right? So we're not in charge of saying who needs to be there. I will say there are some things that we kind of impose. So like we absolutely don't do stress debriefing, right? Whereas 20 years ago in the time of SARS, that's what we were asked to do, right? And there wouldn't have been good evidence to say no at that point, although we tried and it didn't seem very useful. But I mean, we do follow our evidence base as well as we can to say we'll do things that have a reasonable chance of being useful and where there's some evidence for their utility, and we won't do things that are not helpful and potentially harmful, right? So, but mostly we're just trying to match the what we perceive to be the needs of the units that we're at.
You mentioned the fact that the physicians are hovering in the background, and of course that kind of undermines the whole process. And we know from the Schwartz rounds, for example, the importance that consultants not only attend, but they also deliver, you know, and contribute significantly to it. I have a question from one of our members here who's asking that they found that in their sports rounds that they deliver, that some of the themes that you've mentioned in your own coaching sessions have come up. And have you any suggestions for how do you work with senior managers to try and take some of those themes and actually, you know, try and correct them or respond to them?
Yeah, we've, I guess one of the advantages of this being a marathon is that you get to pick your moments for dealing with senior managers. I think one of the most consistent things is that nobody has any time. And so like the idea that we would have a kind of regular standing meeting with senior managers is like a non-starter in our environment. So we're kind of a medium-sized hospital. We've got like, I don't know, 5,000, 6,000 people or something, to give you an idea of scale. And which means that we have a large enough kind of senior management group that we can kind of find allies and build relationships and work with the people who like to work with us, which is what we do. It's what we do as CL psychiatrists, and it's what we do as coaches. It's what we do everywhere, right? Is try and build relationships and work with relationships. I think that's called soft power in politics. And then I think one of the things that comes from that is when the executive are feeling that things are not going well, or that they have questions and stresses that they need to deal with, that don't have the expertise for, they know who to talk to, right? And those are the moments where I think we have more influence than in any kind of structured planning sense, where our input is one piece among the many that are being received, and I'm not sure that it's actually as influential.
Was there any formal relationship between your group, the coaches, and management at the beginning? And I'm mindful that you said you didn't want people in the huddles to feel that you were kind of the hospital management spies and reporting back. And because I would imagine if there was that openness for them to hear some of the issues, there might be a more genuine, and I mean, I am absolutely sure managers want to support us in the roles that we're doing. But it's about sometimes one size doesn't fit all approach is hard.
Yeah, I think those relationships between psychiatry and the executive were well formed beforehand. I think that's one of the consequences of SARS actually, is that this kind of standing of psychiatry within the hospital rose because they were seen to have having kind of been useful at a time of crisis. And that was kind of reinforced in all of the pandemic planning towards H1N1. And one of the things that we learned at that time, that pandemic planning period, was that one of the most valuable things that we did then, I think, were to surface concerns and then bring them to senior management and be really explicit that that's what we were doing, that we're having a discussion with some department or some unit, and we'll do a little bit of teaching and we'll talk about coping, but the meat of this is then we're going to have a discussion. You tell us what your concerns are, you tell us how you think the problems can be fixed, and we're going to raise that with senior management. And we did, not always with an immediate response, of course, right? It just kind of begins a conversation. But I think the idea that the conversation was happening from the bottom up was really valuable to the people who are closer to the front line.
Could I end, because I'm aware we've stolen a little bit of time from our audience and indeed your breakfast, but can I end with a bit of a practical question, which is, you mentioned that at times when you're having the huddles, that one of the roles is, to gently bring in some of the maybe reflective components, and you said you might mention about to somebody, reinforce, normalize, the use of the 3 coping strategies, for example. Could you just kind of give, because again, in this group of people, you'd have, you know, I won't say the anaesthetists or the surgeons are the least psychologically minded, but also you've different levels of expertise within the group. You've other psychiatry colleagues. So how might you approach that without dumbing down, you know, your message, and at the same time, you know, making it meaningful to the group? How might you, you know, bring that into a session?
Yeah, so the coping is a good example of that, because what we say about the coping framework, which is like to exactly speak to how to present something simple without dumbing it down, is to say everybody already knows how to cope. I'm going to tell you some things that you already know. But the reason that I'm telling you this is that in the moment where you're feeling overwhelmed, you're going to forget that you know how to cope, because that's what human beings do. And so it's helpful for us to have a really explicit method of reminding ourselves what we already know, right? And so all of these 3 stages of coping do is to make the implicit explicit. Right? So this is just a way of framing your knowledge. So step 1, I don't even need to tell you about, because step 1 is problem solving, and you are experts at problem solving. That's why you do the job that you do. That's why it was attractive to you. So step 1 is to fix things, and we don't need to talk about how to do that. So on to step 2, which is how do you deal with the things that you can't fix, which is most of what people actually think is coping. And those are those are the things that you need to do to help yourself feel better. And here's the list. And there's nothing surprising on the list, but it's good to have reminders, right? So you need to take care of yourself physically. So you need to have good nutrition, maintain your sleep, right? You need to exercise moderately. It's good to have a sense of humor. It's good to have friends. The more time you spend in relationships that make you feel better about yourself, the more you're going to be able to cope with having bad feelings. And there's some other things on that list, but they're all kind of focused on what do you do in order to feel well enough at the end of the day when you can't fix problems. And the 3rd stage for the really enduring suffering that we all experience from time to time is to remind ourselves why we're doing this in the first place. And for healthcare workers, the easiest way to think of that, for some people that's religion and other values, family and important personal values. But for healthcare workers, the one that most of us have in common is, why did we start doing this work in the first place? Because that's why we're showing up at a place that we're finding stressful and enduring work that makes us feel burnt out sometimes, because it had some value to us in the first place. And so it's helpful just to reflect on what that value is. So that's the spiel, right? That takes, I don't know, whatever that took, 45 seconds. It's simple. I don't think it's dumb, but it's simple. And I think it's helpful for everybody, no matter how sophisticated they already feel about the science of what they do, and even who feels sophisticated about psychology and coping. I mean, we all get befuddled by things that feel overwhelming.
As you say, easy to do, but so expertly said there, Bob, as indeed was your whole presentation. So I want to end, just because I know I have the luxury of maybe chatting to you for a few minutes in the chat room, but I just want to end for our audience and to thank you very much for, I suppose, reminding us of that ABC, you know, looking after ourselves at this time, and knowing when, you know, we're reaching our capacity, and you know, when we need to take a break. We will be having many more COVID seminars, and I'm sure we'll return to this issue because it is a need of constant change, and also organizational support needs to change as we enter the different phases of this pandemic. We've got over the acute response that, you know, happened back in February, March, perhaps for Ireland, and probably about the same time for yourself. I would just like to draw the audience attentions to an occupational stress and burnout among healthcare workers conference that we're running on the 16th of October. And please make a note of it. Next week, hopefully, we'll have the link that you'll be able to actually register for the course. And we are hoping that many of you might sign up to it. A little plug is that we are charging a small fee for this, having done all the webinars for nothing, but we're hoping that we'll be able to use this money towards, we've been very lucky to receive funding from the AIB Bank for a Newman Fellow for the next 2 years. And Dr. Gavin and I will be researching the area of healthcare worker stress and burnout. And, you know, hopefully many of you in the audience might be interested in your departments coming on board and being part of that. But any funds that we get from this conference will go towards that research. So the second thing I just want to say to you is that our next week's speaker is Dr. Mimi Simic, who many of you working in the area of certainly child eating disorders will be very familiar with. But she will cover, you know, all ages as well. So we hope that you will join us there. So once again, a big thank you to the sponsors and the people that have helped us continue to have the show on the ground, Paul and Bloned, and for the College of Psychiatry support as well. And the last thanks to Bob for giving this talk before what you should be doing, which was having your breakfast before you came on board. But I might chat with you in the chat room for a moment. Thank you. Bye-bye, everybody. Have a good weekend. See you next week.
Thank you very much.